Welcome to Chapter 27, entitled Pharmaceutical Care in Asthma and Chronic Obstructive Pulmonary Disease. The pharmaceutical care philosophy and framework fit in perfectly with the needs of patients with asthma and chronic obstructive pulmonary disease. Ample evidence exists to demonstrate the positive impact that pharmacists have had in these patients when conducting interventions in inhaler technique, reviewing medication, and managing drug-related problems, abbreviated as DRPs. Pharmacists taking the lead in coordinating the patient's medication matters will contribute to overcoming issues arising from fragmented healthcare systems. Caring for patients by personalizing interventions is the key to achieving optimal outcomes. Next we will discuss disease characteristics. Asthma and chronic obstructive pulmonary disease, abbreviated as COPD, are two common chronic conditions affecting the lower respiratory tract. Although they tend to present with similar symptoms and are managed using the same types of medication, they are two distinct conditions with varying underlying pathophysiology. This is appropriately illustrated by the definitions provided by the two global bodies dedicated to asthma and chronic obstructive pulmonary disease: Global Initiative for Asthma, GINA, and Global Initiative for Chronic Obstructive Lung Disease, GOLD. Asthma is a heterogeneous disease, usually characterized by chronic airway inflammation. It is defined by a history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. Chronic obstructive pulmonary disease is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities usually caused by significant exposure to noxious particles or gases. There are some patients, usually above the age of 40 years, who may present with characteristics of both asthma and chronic obstructive pulmonary disease. This is characterized by persistent airflow limitation with several features usually associated with asthma and several features usually associated with chronic obstructive pulmonary disease. It is therefore identified in clinical practice by the features that it shares with both asthma and chronic obstructive pulmonary disease. Next we will focus on asthma. It is estimated that there are approximately 235 million people worldwide who currently suffer from asthma. Asthma is found in all age groups. However, it is the commonest chronic disease in childhood. If inappropriately managed, asthma can lead to death. The World Health Organization, WHO, estimates that in 2015, there were 383,000 deaths due to asthma. The risk factors for the development of asthma are both genetic and environmental, with atopy being a major risk factor. Asthma is characterized by airway inflammation, which is due to the release of chemical mediators from inflammatory cells, mucus hypersecretion leading to bronchoconstriction and reversible airflow obstruction. Generally, patients may have extended periods of being well controlled and yet may still experience a severe exacerbation. Next we will look at comorbidities in asthma. Patients who present with asthma may also have comorbid conditions which need to be managed for optimal control of asthma. Allergic rhinitis is the commonest comorbidity in asthma. Lack of treatment or inappropriate treatment of allergic rhinitis in patients with asthma may lead to ineffective control of asthma. The ARIA guidelines, an abbreviation for allergic rhinitis in asthma, provide detailed information for pharmacists' intervention in this patient group. Other atopic conditions are also frequently present and need to be managed accordingly. Obesity makes asthma more difficult to control and weight management needs to be addressed in obese individuals. Mental health problems, particularly anxiety and depression, are a frequent occurrence and if left untreated will have a significant negative impact on asthma control and quality of life. Next we will discuss chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease currently affects over 300 million individuals, and it is estimated to become the third leading cause of death by 2030. Patients with chronic obstructive pulmonary disease tend to be over 40 years of age, with a history of smoking and/or exposure to noxious substances which may be environmental and/or occupational. Younger patients who present with chronic obstructive pulmonary disease usually have predisposing factors which are genetic, such as alpha-1 antitrypsin deficiency and abnormal lung development. The most frequently encountered respiratory symptoms of chronic obstructive pulmonary disease are dyspnea, cough and/or sputum production. The presence of wheeze and chest tightness is variable, while fatigue, weight loss, and anorexia may also be present when the condition becomes severe. Chronic obstructive pulmonary disease is characterized by exacerbations and comorbidities. And now we will look at comorbidities in chronic obstructive pulmonary disease. Patients with chronic obstructive pulmonary disease tend to be multi-morbidity patients presenting with other chronic conditions which may impact the progression of chronic obstructive pulmonary disease and need to be managed according to their respective treatment guidelines. The main comorbidities present in chronic obstructive pulmonary disease patients include cardiovascular diseases, in particular heart failure, osteoporosis, anxiety, depression, metabolic syndrome, diabetes, bronchiectasis, obstructive sleep apnea, and lung cancer. Most of these comorbidities may also be caused by smoking or may be associated with medication used to treat chronic obstructive pulmonary disease. And now we will discuss treatment goals. The treatment goals presented here are mainly based on GINA and GOLD. Many countries and possibly regions have their own guidelines which take into account the local healthcare system, the specific needs of the population, local resources, and cultural issues. Using guidelines which have been adapted to local communities makes treatment goals more achievable and is in line with whose vision of responding to the needs of the specific communities. We will now shift gears to multidisciplinary management. Asthma and chronic obstructive pulmonary disease both necessitate multidisciplinary management, with guidelines highlighting the essential contribution of pharmacists in optimizing medicines use and improving health outcomes. Building a working professional relationship with other healthcare professionals takes time, commitment, and various skills. Establishing methods of open, effective communication, both formal and informal, will improve the chances of functioning in the best interest of the patient. Pharmacists' ability to take the lead in coordinating matters pertaining to the patient's pharmacotherapeutic management will contribute significantly to fulfilling the treatment goals. We will now focus on knowing your patient and personalizing interventions. When setting treatment goals, it is necessary to take into account the patient's own goals and not just the standard expected outcomes of therapy. Taking into consideration the individual patient's beliefs about their condition and attitudes in relation to their medication is of paramount importance. Understanding the individual patient's needs, including assessing the level of literacy and identifying which intervention works best, will enable the development of a more effective personalized approach. Engaging patients, listening to their concerns and expectations while communicating effectively will contribute considerably to achieving the desired treatment outcomes. Next, we will consider attaining and maintaining the treatment goals. Attaining and maintaining both the long-term and short-term goals of treatment, which become apparent over the course of patient care, necessitate routine and systematic monitoring and assessment. Appropriate documentation is essential to review patients' progress toward attaining and maintaining treatment goals. Next we will discuss treatment goals for asthma. While the management of asthma is dealt with separately in terms of age group, the treatment goals are the same. The ultimate aim of asthma treatment is complete control, which is defined as no day or nighttime symptoms, no need for reliever medication, no limitation on activities and normal lung function, this being achieved with ideally no or negligible adverse effects from medication. We will now consider achieving good symptom control. The symptoms of wheeze, shortness of breath, chest tightness, and cough are very disturbing and limiting for patients. Patients may experience any one, all or any combination of the above with varying intensity. They may be experienced at different times throughout the day or, if less well controlled, during the night. With appropriate management, patients are able to lead a relatively symptom-free life. Patients should not accept their symptoms or allow them to pose limitations on their lifestyle. And now let's look at maintaining normal levels of activity. The first step is to identify what the individual patient's normal is and aim at that level. For children, attending school, engaging in games with friends, activities and sports without feeling different from their peers may be the desired normal. For young people, normal could be going to work and having a social life without needing to explain their symptoms. Other people may want to conduct normal daily activities such as shopping, gardening or simply walking, and climbing stairs without taking frequent breaks. Engaging in sports and physical activity is encouraged, and having asthma should not be considered a barrier to being fully active. We will now look at minimizing risk of exacerbations. Patients may experience an exacerbation whether they are well controlled or not. However, the less controlled they are, the higher the probability of experiencing an exacerbation. And now we will consider limiting side effects of treatment. The aim is to achieve optimal control and quality of life using the least number of medicines, at the lowest possible dose with a minimum of adverse effects. Adverse effects of medication may, at times, go unnoticed by the patients themselves, or they may be prepared to accept them and not bring them to the attention of the practitioner. Alternatively, they may unilaterally decide to modify their prescribed therapy or stop their therapy altogether. Next we will discuss treatment goals for stable chronic obstructive pulmonary disease. The treatment goals for stable chronic obstructive pulmonary disease may broadly be seen as twofold: symptom reduction and risk reduction. The aim is to achieve these goals with a minimum of adverse effects from the medication being used to treat both chronic obstructive pulmonary disease and the comorbidities present. And now we will focus on symptom reduction. As the condition progresses, the characteristic symptoms of chronic obstructive pulmonary disease increase in frequency and intensity, imposing significant limitations on exercise and daily activities, as well as having a general negative impact on health status. Patients tend to accept their symptoms and adapt their lifestyle to their increasingly limiting symptoms, which may lead to underestimating the severity of their condition. The aim is, therefore, to relieve symptoms, improve exercise tolerance, and improve overall health status. Next we will discuss risk reduction. The higher the exposure to risk factors, such as tobacco smoke, indoor and outdoor air pollution, and occupational exposure, the higher the probability of disease progression, exacerbations, and mortality. The treatment, therefore, aims to prevent the progression of chronic obstructive pulmonary disease, to prevent and treat exacerbations, to prevent and treat complications, and to reduce mortality. We will now discuss management of the diseases. The management of asthma and chronic obstructive pulmonary disease requires both a pharmacological and non-pharmacological approach. Generally, the management entails pharmacotherapy, education including supported self-management, appropriate use of inhalation devices and monitoring. Medication delivered by inhaled therapy is the hallmark of the pharmacological management of these two conditions. Both conditions necessitate the selection of appropriate drugs and delivery devices which have a crucial role in achieving the successful outcomes of therapy. While there is a significant overlap in the medication used to manage asthma and chronic obstructive pulmonary disease, it is essential for the delivery of optimal pharmaceutical care to be aware of the appropriate diagnosis, since the medication is used differently in different conditions. Education, coupled by appropriate interventions to support behavior change, is an essential component of management. Education needs to impart to patients and their caregivers the necessary skills to cope with their condition. An educational intervention has a better chance of having an impact if commenced after a professional relationship and partnership with the patient has been established. It is essential to address issues that are important and relevant to the patient, taking into account any misconceptions, fears, concerns, and should be culturally sensitive. The intervention needs to be delivered in a manner and a language which can be understood by the patient. Educational interventions target the patient as well as the family and caregivers. Education is an ongoing process and key messages should be reinforced at every opportunity. Monitoring of various parameters is an integral part of management to be conducted by both healthcare professionals as well as the patients themselves and, when appropriate, their caregivers. Patients need to be supported and empowered to take increased responsibility and actively participate in the management of their condition. Recent systematic reviews have clearly demonstrated that pharmacists' educational and monitoring interventions delivered as structured programs are highly effective in achieving the desired positive outcomes in asthma. With the exception of improvement in inhaler technique, it is rather more challenging to find evidence demonstrating pharmacists' positive interventions when delivering a structured program for chronic obstructive pulmonary disease patients. There are abundant reasons for this, some of which are the following. Since it is a highly complex condition, patients require complex interventions which include the monitoring and control of comorbid conditions as well as medications for those conditions. Education and monitoring of chronic obstructive pulmonary disease in isolation is unlikely to yield the desired results. Chronic obstructive pulmonary disease is a progressive disease. Therefore, even if there is improvement in various parameters, this may be offset by the nature of the disease. The study designs of publications related to pharmacists' interventions in chronic obstructive pulmonary disease are also problematic, as very often they include both asthma and chronic obstructive pulmonary disease patients and have the same outcomes. The two diseases should be studied separately and studies designed accordingly. There is evidence to demonstrate that pharmacists' interventions in chronic obstructive pulmonary disease had a positive impact on knowledge, adherence to therapy, medicine's beliefs, and drug-related problems in addition to inhaler technique. A systematic review studying educational programs in chronic obstructive pulmonary disease management argued that while most of the interventions were carried out by nurses, physicians, and physiotherapists, including pharmacists, could lead to better management and outcomes. Next we will look at inhalation devices. There is robust evidence demonstrating the positive outcomes achieved following pharmacists' interventions on inhaler use in asthma and chronic obstructive pulmonary disease. Prior to instructing the patient on the use of an inhaler, It is essential for pharmacists to have mastered the use of the devices available and have the resources to use in teaching the appropriate technique. There are a plethora of different types of inhalation devices available. These include pressurized metered dose inhalers, abbreviated as PMDIs, used with or without spacers, breathe-actuated pressurized metered dose inhalers, soft mist inhalers, single-dose and multi-dose dry powder inhalers, and nebulizers. Inhalation devices are complex, with their design and construction, taking into account the need to generate a respirable aerosol and the patient's ability to inhale the aerosol into the lungs. The projected therapeutic effect of the drug being delivered by an inhaler is based on the assumption that the inhaler will be used as instructed. Incorrect use of the device will lead to a decreased therapeutic effect and loss of control of the disease and the possibility of increased adverse effects, as in the case of inhaled corticosteroids. Pharmacists are the healthcare professionals whose training best equips them to fully appreciate the basic science behind the device as a delivery system, the pharmacological effect of the drug delivered, and the practical needs of the patient. Next, we will look at assessing suitability. Assessing the suitability of the inhaler device prescribed is important both in the case of a patient being prescribed a specific type of inhaler for the first time as well as for a patient who has been using the inhaler for some time. Various factors need to be taken into account when assessing suitability, such as the patient's inspiratory ability and the patient's physical and mental ability to use the device. The choice of device is at times closely linked to the drug selected, and this can be a limiting factor for selecting the most appropriate device for the patient. Another issue is accessibility. Prescribing devices that are not affordable to the patient leads to non-adherence. Cost and availability of devices vary in different countries. The choice of inhaler should take into account the individual patient's needs, circumstances, and preferences. And now we will look at instructing and assessing technique. The importance of teaching patients how to use their inhalers is of paramount importance. Based on the assessment of the patient's abilities, an appropriate inhaler technique education intervention can be drawn up. This may vary from one individual to another, and the more the intervention is tailored to the individual, the better the chances of success. Using placebo inhalers to teach the technique has been found to be effective. In the absence of placebos, the patient's own inhalers may be used. Verbal, audiovisual and written instructions are all useful methods. Using the teach back method will enable the pharmacist to assess the effectiveness of the intervention. More instructions may be needed at that point. Depending on the patient, the pharmacist must decide whether to continue with the intervention or set a follow-up appointment. Pharmacists need to be aware of common errors which patients make when using inhalers and should be well equipped to identify and intervene appropriately. It may be evident from the start that the patient is unable to use the prescribed inhaler, such as when there is limited physical dexterity, or is unable to comprehend instructions, etc. Communicating the problem or problems to the prescriber and suggesting another type of inhaler or therapy would be the preferable approach. Next, we will consider reviewing technique. Reviewing the patient's technique on a regular basis, on average every 4 to 6 weeks, is also important, as the ability to use the inhaler properly can diminish over time. Regular reinforcement of inhaler technique is essential for the patient to maintain the ability to use the device properly. Checking the steps of use for the specific type of inhaler against a standard list of steps is practical and relatively easy to conduct. Any steps which the patient has carried out incorrectly can easily be identified, corrected, and the technique once again reinforced. And now let's consider simplification of therapy. Some patients present with a range of different types of inhaler devices. The use of several different types of devices makes it confusing and more difficult for the patient to master the various steps required for the diverse devices prescribed. Recommendations to the prescriber to, as much as possible, select the same type of device will enhance the probability of appropriate inhaler technique. Maintaining the number of devices to a minimum should also be taken into account. It is advisable for a medication review to include an assessment for the need of the number of devices prescribed. Whenever indicated, recommendations for a decrease in the number of devices ought to be made. Simplification of therapy will make it less confusing for patients, contribute to a better inhaler technique, and adherence to therapy. Next we will look at spacers. Spacer devices are used in combination with pressurized metered dose inhaler, especially in children and in those individuals who are unable to use a pressurized metered dose inhaler appropriately. Spacers selected should be fully compatible with the pressurized metered dose inhaler prescribed. Patients need to be taught how to use this device and how to clean and maintain the device as per manufacturer's instructions. And now we will focus on oxygen cylinders. Patients on domiciliary oxygen using oxygen cylinders and concentrators need instruction and counseling on their appropriate use and care. Next we will look at pharmacological management of asthma based on symptom control. Inhaled corticosteroids, abbreviated as ICS, are the cornerstone of therapy in asthma and are considered to be first-line therapy. They are usually referred to as controllers or preventers. In most patients, treating with regular low-dose inhaled corticosteroids will lead to a reduction in asthma symptoms, increase in lung function, improvement in quality of life, and a reduction in risk of exacerbations, hospitalizations, and death. It is only in patients who experience very occasional daytime asthma symptoms that inhaled corticosteroids are not currently recommended. The dose of inhaled corticosteroids is increased or decreased and used in combination with other medications depending on the patient's clinical need. Inhaled beta-2 agonists may be short-acting, abbreviated as SABAs, which are relievers, or long-acting, abbreviated as LABAs, which are classified as preventer controllers. Short-acting beta-2 agonists are recommended for, as required use, in all asthma patients to relieve symptoms. In patients who only experience symptoms infrequently, such as occasional wheeze lasting for a short period of time, they are currently the only recommended therapy. It is currently recommended that long-acting beta-2 agonists are added on to regular inhaled corticosteroids when the desired outcomes are not achieved with low-dose inhaled corticosteroids alone. Oral leukotriene receptor antagonists, abbreviated as LTRA, are also classified as preventers controllers. They may be an alternative in patients unwilling or unable to use inhaled corticosteroids. However, they are less effective than inhaled corticosteroids. They may also be used in combination with inhaled corticosteroids long-acting beta-2 agonists to achieve and maintain control. Other add-on therapy options include tiotropium, which is a long-acting muscarinic antagonist, abbreviated as LAMA, delivered as a soft mist inhaler, is used in adult patients with a history of exacerbations. However, the evidence supporting this use is not robust. Oral theophylline is sometimes used in adults, although not recommended for regular use. The chromes, inhaled nedochromyl sodium and sodium chromoglycate, are still available. However, they have a rather low efficacy. In patients who have severe allergic uncontrolled asthma, anti-immunoglobulin E, abbreviated as anti-IgE, omalizumab, is an option, while in severe uncontrolled eosinophilic asthma, subcutaneous mepolizumab and intravenous reslizumab are available in some countries. Low-dose long-term oral steroids may be used in adults with severe asthma, who have failed to achieve control on inhaled controller, preventer therapy. Next we will discuss common drug-related problems in patients with asthma. Table 27.1 uses the PCNE drug-related problem classification to illustrate some of the common DRPs that are manifest in patients with asthma. We will now focus on education, supported self-management and monitoring in asthma. Patient education is essential to empower patients and support them to manage their condition. Various resources are available which can be used in educational interventions. Providing a brief overview of asthma, its underlying causes, manifestation or symptoms, risk factors, what to expect from the disease and how it may affect lifestyle will help patients better understand their condition. Addressing triggering factors and appropriate avoidance strategies as well as delving into patient-specific modifiable risk factors could contribute to maintaining better control. Enabling patients to identify the deterioration in condition or loss of control, which may lead to an exacerbation, and how to deal with the situation, including how to access help, is an essential part of the educational intervention. Educating patients on their different types of medication, preventer controllers, relievers, how they work, why they are needed, when to take them and how to appropriately use the various inhalers is imperative. Depending on the individual patient, advising on smoking cessation and avoidance of tobacco smoke and weight loss in cases of obesity is also a necessary part of the intervention. Individualized action plans where patients adjust their medication requirements depending on their level of symptom control and peak expiratory flow rate have been shown to be highly effective. Empowering patients to take increased responsibility in the management of their asthma leads to positive outcomes. Personalized self-management plans are drawn up by the care team and tailored to the needs of the individual, taking into consideration the ability and the desire to follow the plan, as well as level of literacy. Pharmacists' involvement in drawing up the plan, monitoring and intervening to enable the patient to attain and maintain the treatment goals is an integral part of the delivery of care. Additionally, facilitating a plan for those individuals who require one is another essential intervention. Monitoring of various parameters in patients with asthma is essential to maintain control and have a good quality of life. The British Thoracic Society clearly highlights the parameters that need to be monitored, all of which pharmacists can contribute to through the delivery of pharmaceutical care. Reviewing the patient in a structured and planned manner leads to better outcomes than using a casual, unplanned approach. Symptoms can be monitored by pharmacists in a structured manner using a variety of tools available, such as the 30-second asthma test and the widely used asthma control test, abbreviated as ACT. These tools are easy to use and take up very little time. Lung function can be monitored using a peak flow meter. Patients can use a peak flow meter to monitor their lung function, and these can be reviewed by the pharmacist. Monitoring peak flow is mostly useful in those patients with severe asthma. Asthma exacerbations, the use of rescue courses of oral glucocorticoids, as well as the number of days taken away from work or school also need to be monitored, as these give an indication of the degree of control of the patient's asthma. Inhaler technique can be monitored as explained earlier. Standardized asthma checklists like those produced by the National Council of Australia are useful as they offer a structured categorical approach to assessing inhaler technique. As indicated in Chapter 5, adherence to therapy is an important parameter that needs to be monitored, certainly in asthma. It is well known that adherence is low in patients with chronic disease. It is indeed a challenge to accurately assess adherence to preventer therapy. Some ways include checking how many prescriptions have been filled or asking patients how many times they have forgotten to take their medication over a short period of time. While none of these approaches provide accurate information, they do give an indication of the degree of adherence by the patient. Short-acting bronchodilator use monitoring provides information as to whether patients are overusing their reliever inhaler, which is another indicator of inappropriate management and loss of control. Using more than one short-acting bronchodilator per month is a clear indicator of poor asthma control. Pharmacists should monitor patients for any drug-related problems, including the emergence of adverse effects of their current therapy. This will allow for timely interventions. Next we will discuss management of chronic obstructive pulmonary disease. Let's begin with pharmacological management of chronic obstructive pulmonary disease. Pharmacological management of chronic obstructive pulmonary disease has been shown to positively impact a number of parameters, including a reduction in symptoms, a reduction in frequency and severity of exacerbations, as well as an improvement in health status and exercise tolerance. Each treatment regimen in chronic obstructive pulmonary disease needs to be individualized. However, none of the therapy used to date has managed to have an effect on the long-term decline in lung function. Bronchodilators. In chronic obstructive pulmonary disease, the mainstay of therapy is bronchodilators, which are primarily used to prevent or reduce symptoms. Short-acting beta-2 agonists and long-acting beta-2 agonists are most commonly used, although the use of short-acting beta-2 agonist on a regular basis is not a preferred option. The use of long-acting beta-2 agonists has a positive effect on lung function, dyspnea, health status, exacerbations, and hospitalization rate. Long-acting muscarinic antagonists have been found to improve health status, pulmonary rehabilitation, and lead to a reduction of exacerbations and hospitalizations. Combining beta-2 agonists and antimuscarinics will usually have an enhanced therapeutic effect without leading to an increase in adverse effects. Various inhalers containing a combination of bronchodilators are available. Methylxanthines, such as theophylline, are also used in chronic obstructive pulmonary disease. However, the optimal manner in which they should be used is still open to debate. Anti-inflammatory agents. The use of inhaled corticosteroid in chronic obstructive pulmonary disease is still unclear, and their use needs to be balanced with the risks involved. While the use as monotherapy is not recommended, there are some advantages in using them in combination with long-acting beta-2 agonists and long-acting muscarinic antagonists. Triple therapy of inhaled corticosteroid, long-acting muscarinic antagonist, long-acting beta-2 agonist has been found to improve lung function, symptoms, health status, and exacerbations when compared to either long-acting muscarinic antagonist alone or the inhaled corticosteroid long-acting beta-2 agonist combination. Phosphodiesterase 4 inhibitors reduce exacerbations in those who have chronic bronchitis, severe to very severe chronic obstructive pulmonary disease, and a history of exacerbations. They do not appear to have much effect on symptoms and quality of life. The use of the macrolides azithromycin and erythromycin is useful in reducing exacerbations over a 1-year period. The regular use of mucolytic and antioxidant agents may be useful to reduce exacerbations and improve health status in chronic obstructive pulmonary disease patients not on inhaled corticosteroid. Patients with chronic respiratory failure who present with severe resting hypoxemia benefit from long-term administration of oxygen, that is greater than 15 hours per day, by increasing survival. Important safety considerations. While the management of asthma and chronic obstructive pulmonary disease involves the use of inhaled corticosteroids and bronchodilators, their safety recommendations are opposite. In the case of asthma, long-acting beta-2 agonists and long-acting muscarinic antagonists should never be used without inhaled corticosteroid. In chronic obstructive pulmonary disease, treatment is initiated with long-acting beta-2 agonists and/or long-acting muscarinic antagonists without inhaled corticosteroid. Next we will look at drug-related problems in chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is a multi-component disease which affects various organs. When treating and managing chronic obstructive pulmonary disease, one does not just focus on the lungs but the entire system. Patients with chronic obstructive pulmonary disease tend to use many medicines to treat their various comorbidities. The drug-related problems which they experience are multiple and do not just relate to respiratory medicines. Therefore, a review needs to take into account all these issues. For practical reasons, Table 27.2 addresses mainly drug-related problems related to respiratory drugs. However, this only presents a partial picture and is far from comprehensive. Pause the video and carefully scrutinize Table 27.1 summarizing commonly encountered drug-related problems in asthma patients before advancing to the next slide. Pause the video and carefully scrutinize Table 27.1 summarizing commonly encountered drug-related problems in asthma patients before advancing to the next slide. Pause the video and carefully scrutinize Table 27.1 summarizing commonly encountered drug-related problems in asthma patients before advancing to the next slide. Pause the video and carefully scrutinize Table 27.2 summarizing commonly encountered drug-related problems in chronic obstructive pulmonary disease patients before advancing to the next slide. Pause the video and carefully scrutinize Table 27.2 summarizing commonly encountered drug-related problems in chronic obstructive pulmonary disease patients before advancing to the next slide. Next we will look at education, supported self-management and monitoring in chronic obstructive pulmonary disease. Educational interventions in chronic obstructive pulmonary disease require addressing by a multidisciplinary team which may include, among others, physicians, nurses, pharmacists, physiotherapists, occupational therapists, and psychologists. The educational intervention, therefore, requires a structured and coordinated approach. Pharmacists' primary contribution is in engaging patients in smoking cessation programs and addressing exposures to other irritants and risk factors. Educating patients about their condition, its progression, early recognition of exacerbations, and how to handle the situation is an essential part of the educational strategy. Pharmacists can counsel patients about their different types of medication, how they function, the rationale behind their use, and what to expect from their therapy, including the recognition of possible adverse effects together with instructing on inhaler technique as described earlier and provide advice on appropriate vaccinations. Supporting patients to develop self-management skills has been found to positively influence outcomes in chronic obstructive pulmonary disease. The main skills that pharmacists can address include helping patients to identify and control triggers and control symptoms, handle an acute episode or an emergency, navigate the healthcare system and services, and making appropriate use of the various healthcare professionals. The skills related to medicine taking, including how to use their inhalers, always need reinforcing. In addition to these skills, There are various other skills such as dietary interventions, physical, and psychological techniques which are usually addressed by other members of the team. The best outcomes are achieved when these skills are part of an action plan drawn up for the individual patient. Monitoring for the appropriate use of therapy, adherence to therapy, and for the emergence of drug-related problems, especially ADRs, is vital in the management of chronic obstructive pulmonary disease. Symptom monitoring could be conducted using various tools which are available, such as the Chronic Obstructive Pulmonary Disease Assessment Test, abbreviated as CAT. These tools only provide an indication to the pharmacist and are by no means a comprehensive assessment of chronic obstructive pulmonary disease. Monitoring of comorbidities according to the relevant guidelines is important as they significantly influence mortality and hospitalization. Next we will discuss delivery of pharmaceutical care to asthma and chronic obstructive pulmonary disease patients. And now we will look at developing patient-centered pharmaceutical care for patients with asthma. The philosophy and care model of pharmaceutical care fits perfectly with the needs and management model for asthma. Delivery of pharmaceutical care to asthma patients has resulted in positive therapeutic and patient outcomes coupled with high patient satisfaction. Figure 27.1 provides an overview of the pharmaceutical care cycle for asthma. Pause the video and carefully scrutinize Figure 27.1 illustrating pharmaceutical care program for asthma before advancing to the next slide. Pause the video and carefully scrutinize Figure 27.2 illustrating pharmaceutical care pathway for chronic obstructive pulmonary disease before advancing to the next slide. Next we will discuss delivering patient-centered pharmaceutical care for patients with chronic obstructive pulmonary disease. The increased knowledge gained about chronic obstructive pulmonary disease over the past years has presented a better opportunity for the delivery of pharmaceutical care to patients with chronic obstructive pulmonary disease. Currently, the recommendation is for a highly flexible program dependent on the stage of the condition and the needs of the individual. Figure 27.2 provides an overview of the pharmaceutical care cycle for chronic obstructive pulmonary disease. We will now discuss a case scenario. Miss FC is 30-year-old overweight female with a hectic lifestyle who usually collects her asthma prescriptions from your community pharmacy. One early autumn afternoon, she presents at your pharmacy to collect her elderly mother's prescription. You notice that she has an upper respiratory tract infection, a chesty cough, and you also detect a slight wheeze. You ask her if she is managing her cold and symptoms. She replies that she does not want to take any medication because she is trying to get pregnant. In fact, she has also stopped taking her asthma medication and felt fine during the summer months. She tries to put up with her symptoms as much as possible and takes a few puffs of her reliever, salbutamol, as a last resort. However, now it is getting to be very difficult. She wants her body to be free from steroids when she gets pregnant. On checking her profile, you note that her current prescription is for a combined dry power inhaler of formoterol 6 micrograms per dose and budesonide 200 micrograms per dose, to be taken as 2 puffs daily, 1 puff every 12 hours, in addition to salbutamol as a metered dose inhaler, to be taken as required. The last time that she collected her prescription was over 3 months ago. Pharmaceutical care interventions. There are a number of important issues that need to be addressed by the pharmacist. Initial assessment and identification of problems. Miss FC is clearly misinformed about her asthma medication use before and during pregnancy. This has led to non-adherence to therapy and loss of asthma control. Her cold is about to precipitate an acute attack. We will now look at a therapeutic plan. Let's begin with immediate action. 1. Counseling. Counsel Miss FC on the importance of taking her preventer medication both when preparing for pregnancy and during pregnancy. The importance of asthma being well controlled during pregnancy for both mother and fetus. Highlight benefits of asthma inhaled medication use as opposed to risks of lack of use. Encourage an open discussion regarding this issue. Provide information, possibly also reliable asthma education websites. 2. Assessment of symptom control using a tool such as ACT. 3. Insist on patient recommencing her preventer therapy immediately. 4. Refer to physician for immediate, same-day, review to prevent further loss of control and precipitation of attack. 5. Advise to keep reliever with her at all times. The following day Miss FC returns from her doctor with a prescription for oral prednisolone 40 mg daily for 5 days, formoterol 6 micrograms per dose and budesonide 200 micrograms per dose, to be taken as 2 puffs twice daily, in addition to salbutamol as a metered dose inhaler, to be taken as required. She is also prescribed paracetamol as required. 1. Update Miss FC's profile including necessary documentation of issues encountered. 2. Dispense medication, advice on dosage regimen of preventer, highlighting changes from previous dose. Advice on oral hygiene following preventer inhaler use and advice on administration of prednisolone. 3. Assess inhaler technique for both the dry powder inhaler and metered dose inhaler against standardized checklist. Conduct any necessary intervention to ensure appropriate inhaler technique. 4. Reinforce counseling regarding the importance of asthma medication use and pregnancy. Encourage patient interaction regarding this issue. 5. Inquire about any other risk factors for asthma and advice or discuss accordingly. 6. Advice on upper respiratory tract infection management and use of paracetamol. 7. Set a follow-up appointment with Miss FC in about 3 weeks. Encourage her to contact you earlier if she needs to. We will now briefly look at follow-up. Miss FC returns for her follow-up appointment. Her condition has improved significantly. 1. Initiate a discussion about medication. Attempt to determine if she is taking her asthma medication and how she is taking it. 2. Open discussion about medication during pregnancy and importance of asthma control during pregnancy and try to ascertain if she is convinced of the need to adhere to medication. 3. Assess of symptom control. 4. Encourage her to take the influenza vaccine. 5. Recommend folic acid supplementation. 6. Discuss and propose the adoption of a healthy lifestyle, including moderate exercise and a healthy diet. 7. Encourage her to drop by or contact you if she needs to do so before picking up her next prescription. Monitoring 2 months later, Miss FC returns to collect her prescription for her asthma medication. She looks well and happy. She informs you that 3 weeks ago she found out that she is pregnant. She is happily following your advice. She is taking her preventer asthma medication regularly, with hardly any need to use her reliever. She is feeling even better than before. She is doing her best to stay healthy, taking folic acid, eating healthy food and incorporating walking in her daily routine. Her pregnancy is being monitored by her doctor and midwife. 1. Assess asthma symptom control. 2. Assess inhaler technique. 3. Advice as necessary. And 4. Encourage her to contact you whenever is necessary. Thank you.